Hi, everyone. Thank you for joining our session today. We're just getting our slides pulled up, but wanted to start off by welcoming you all to our exciting session today, aiming to demystify the future of HIV financing by considering pathways to an equitable and sustainable HIV response. My name is Davina Kanigasabe, a senior technical advisor for HIV with PATH's primary healthcare program. And I'll be co-moderating today with my colleague, Dr. Linda Venotto, senior program director for community and primary healthcare with Results for Development. Next slide, please. Great. The slides should be projecting. So if we can go to the next slide, please, Amy. So there have been a number of studies that have shown that integration, embedded and person-centeredness, and that considers contextual factors and available resources can improve health access, overall uptake and outcomes, as well as efficiencies, enabling more optimized use of available resources. And so as we go into the session and think about mainstreaming HIV services into strengthened health systems to achieve a sustainable and equitable response, really drawing on the premise of inclusive universal health coverage and primary health care reforms. Next slide, please. So we know that UHC is meant to ensure that people have access to the health services they need when, where, and how they need them without financial hardship. And that PHC is the driver for achieving this as the most effective, equitable, and efficient approach to health system strengthening. So with global commitments and as the donor space for health programming constricts, countries have been working to advance one health, one budget, and one M&E plans to progress towards achieving UHC while sustainably ending HIV as a public health threat by 2030. As countries embark on their UHC and PHC reforms, we are now at the critical juncture to consider and take opportunities to ensure HIV services remain available, accessible, affordable, and delivered with quality as part of health system reform efforts. Next slide, please. So during our session today, we wanted to take some time to focus and think about how countries are considering HIV within health reform efforts as they shift towards integrative health financing. We'll kick off with two scene setter presentations to lay the foundation for our discussion with Dr. Lisa Fleischer from the U.S. Agency for International Development, highlighting priorities for advancing sustainable and equitable HIV financing, and Elise Smith from Genesis Analytics, who will share findings from research on financing HIV and PHC integration, followed by George Ogola from PATH Kenya, who will share insights and lessons from Kenya's ongoing health reform process and efforts to integrate HIV into primary healthcare platform. I will then pass on to Dr. Linda Venotto to moderate an open Q&A session and wrap up our session. And so throughout our discussion today, we welcome and encourage engagement in the chat. So please feel free to share your thoughts and any questions you have for our speakers in the chat throughout the session. And we will hopefully be able to cover some of those when we get to our Q&A after our presentations. And with that, I would now like to turn over to Dr. Lisa Fleischer, who will be speaking to global synergies for advancing sustainable and equitable HIV financing. Dr. Fleischer is the chief of the Health Financing Economics Branch with USAID's Office of HIV/AIDS. And Dr. Fleischer, as part of that role, coordinates OHA's work on sustainability to develop and coalesce thought leadership in support of sustainability planning efforts for the HIV response. Over to you, Dr. Fleischer.
Davina, thanks so much, and good morning, good afternoon, and good evening to all of those of you who are joining us today. And thanks so much to the organizers for inviting me to contribute to this session and talk about how USAID is working on the financial sustainability of the HIV response. Next slide. So USAID's leadership for a sustainable global HIV response leverages our unique role as the comprehensive development partner in PEPFAR. And to support advancement of the future state of the HIV response at USAID, we've developed 6 core priorities to sustain impact in and accelerate progress in the HIV response. The 6 core priorities are listed here on the slide, and they are localization, addressing inequities, integration of HIV systems and services with country health systems, supply chain, health workforce, and health financing. And these 6 core priorities are underpinned by a number of USAID-wide priorities that address countries' health goals beyond HIV, including support for health resiliency in the face of climate change, building economic resilience to help communities prepare for and recover from health and development shocks, inclusive development, and larger efforts to reduce morbidity and mortality. Next slide. So at country level, the UNAIDS facilitated and country-led HIV response sustainability roadmap process is unfolding. And the roadmap process will chart the pathway for country-level strategies and actions to achieve and sustain impact. So countries, of course, are at different points on the path towards the 2025 and 2030 global AIDS targets and goals. And they're also at different stages of planning for and sustaining that achievement in the long term. So the roadmaps will really be developed taking into account existing strategies and processes. Broadly, countries are following a two-step process, literally as we speak. And so currently, countries are working to finalize Part A of the roadmap, where they are engaging stakeholders, assessing the current state of the HIV response, identifying their priorities for the response through and beyond 2030, and outlining key steps to reach those goals. Next year, for Part B, countries will outline in more detail how they plan to achieve their HIV response priorities and the plan for monitoring and evaluating the milestones along the way. And we at USAID are supporting several countries to help develop their roadmaps. Next slide. So how does our work at USAID link with this roadmap process to address sustainability and some of the larger global efforts? So the roadmaps are developed under a new approach and framework for sustainability that UNAIDS outlined in the HIV response sustainability primer, which came out earlier this year. And this new framework is holistic, and it encompasses the programmatic, political, structural, and financial dimensions of sustainability. Excuse me. So in that regard, this new framework from UNAIDS aligns quite nicely with the PEPFAR lanes of sustainability, which, as you may know, are political, programmatic, and financial sustainability, and then more recently, partnerships with sort of different development entities that are perhaps non-traditional for the HIV response, like the private sector and multilateral development banks, has also been added. So the new framework from UNAIDS includes 5 components outlined here in this wheel. I know the font is very small, that are required across all countries to achieve the global AIDS targets for 2025 and 2030 and sustain these gains with equity, regardless of country epidemic status and country context. So these domains are political commitment, HIV prevention and treatment programs, management systems, enabling policies, and domestic and international financing. Next slide. So when we at USAID think about, what does the future state of the HIV response look like, kind of in the context of this new framework for sustainability, we were getting a lot of questions from our missions about, really how do we program and implement for sustainability? How do we support countries to really kind of enact these sustainability goals? So what we did is develop a technical reference guide that's an internal resource for our country teams. And this guide was developed with information that's sort of to serve as a menu of options for every technical area of the HIV response that outlines what countries can strive for in the future state within each technical area, and what steps countries can take in the short, medium, and long term, again, to help countries reach the goals that they've outlined in their HIV response sustainability roadmaps or broader health sector strategic plans. So what I'd like to do is share with you a little bit about what we've outlined as options for countries to consider in health financing. And what we've done here is group these options by the 3 functions of health financing. So for example, under revenue raising, we would hope that there would be in the future state effective health system governance that's supported by strategic policies and a framework to outline health sector priorities and the direction for the health sector in terms of the policy environment and as well as the legislative and regulatory environment. We would also want to see predictable and sustainable domestic and donor financing that's in line with country priorities for PHC and UHC, as Davina mentioned a moment ago. In pooling, we would hope to see strong pooling mechanisms with minimal fragmentation to expand financial protection and improve equity and efficiency. And then in purchasing, we would hope that there would be strategic purchasing. We would hope to see provider payment arrangements that incentivize client-centered and quality PHC services and integration of HIV and PHC. And we would hope to see strong PFM systems and processes so that budget execution and formulation and monitoring processes were more effective and efficient. Next slide. So when we think about, what's concrete steps, especially that our missions could take, again, to sort of help implement sustainability from a USAID perspective in line with country goals, we've offered some steps here over the short, medium, and long term. And each of these steps is linked back to the various approaches that I just discussed in the previous slide. So in the short term, for example, we would think about supporting efforts to understand current health sector priorities in the financing landscape, including pooling and purchasing, as well as constraints or bottlenecks to identify ways to align PEPFAR funding with health sector priorities. We could see efforts to collate or generate data to estimate the resource requirements for the HIV response, or other efforts, for example, to assess the status of the extent to which HIV services are included in health benefits packages, the feasibility for their inclusion, and the budget impact of that. In the medium term, so in between sort of the next year to 5 years, we could see efforts to enhance political engagement to advance financial sustainability, particularly to advocate for increased government budget allocations to health. We could see efforts to improve the efficiency and effectiveness of risk pooling mechanisms, support to design or redesign and cost health benefits packages, and efforts also, of course, to strengthen PFM at national and also subnational levels. And so that could, for example, include strengthening the link between health sector priorities and budget formulation, improvements in budget execution, and so on. And then in the longer term, so sort of from 5 years and beyond, we could see efforts to continue to support implementation of health system financing and PFM reforms, reviewing and reforming pooling and purchasing arrangements, and then incorporating blended finance or innovative finance mechanisms to complement what governments are doing to advance UHC and PHC. So that's a little bit about how USAID is thinking about financial sustainability of the HIV response and linked with this broader global context of what countries are doing to outline their priorities as well. So thank you very much, and Davina, back to you.
Thank you, Dr. Fleischer, for providing that grounding on how USAID and UNAIDS are working with countries to support advancement of HIV sustainability efforts, and particularly some of the priority actions that we should be progressing towards over the next 5 years as we work towards those 2030 goals and beyond. I would now like to introduce Elise Smith, a senior associate at Genesis Analytics, focusing on public health, financing, and economic analysis in Africa. She'll be taking us through some of the research that Genesis Analytics has been leading around financing HIV and PHC integration. And over to you, Elise.
Thanks, Davina, and hi, everyone. Nice to be here and talk about the very exciting and topical issue around HIV integration. Next slide, please. So as Davina said, I work for Genesis Analytics. We're based in South Africa, and we have been, over the past year, conducting some work on, especially around and trying to understand the economic evidence around HIV integration, especially into PHC. And how we did some of this work involved conducting a comprehensive literature review, followed by kind of deeper dives into 5 country case studies of examples of where HIV has been integrated. And I think just as a caveat to start is that we focused a lot on only on kind of secondary evidence and what has been or had been published at the time. So I think that's kind of a limitation, and also why I'm so excited to hear what George will be talking about in terms of what's currently unfolding in countries, because I think there is a lot happening. So just to kind of reflect on a couple of key findings from our work. The first is that, especially if we look around the evidence on cost, but also cost effectiveness, the evidence is really mixed, and it seems to be highly context specific. So, for example, where we looked at how integration impacted costs of HIV service delivery in Kenya, for example, even within a specific country, these results can differ in the direction. So in some cases, costs increase, in other cases decrease. So it's really hard to kind of make a blanket statement of how costs react to integration. And I think a large part of this is because integration means different things in different settings and for different people. So it's really hard to compare. But that being said, or maybe just to add to that, another thing that makes it quite difficult to compare is kind of differences in methods used. So we had a great interest in understanding how costs change before and after integration. But when we dug a bit deeper, we realized that very few studies actually do that and compare kind of a non-integrated setting with an integrated setting after, and are able to kind of definitively say how costs changed. But that being said, we do see, I think, which is kind of a well understood concept around integration, is that when you integrate vertical services into horizontal services or integrated services, it does lead to certain efficiencies. And a lot of this has to do with utilizing kind of overheads or capital costs better. So, you know, you have one nurse now providing multiple services, and that cost is now shared among more services and more clients. The same with capital costs, for example, so, you know, buildings, etc. And this leads to unit cost savings. So if we think about the cost per client seen, costs tend to decrease. However, what is clear is that, you know, it doesn't necessarily always result in a saving at the total cost level, and this has implications for government budgets when they then plan to absorb vertical services into PHC. And then just some other interesting observations. So, for example, where we did see, or we did see in some cases where direct costs actually increase when HIV services are integrated. So, for example, diagnostics, supplies, drugs. So even if we look at a per patient cost, this goes up, and the data is really not well described in most cases, but kind of the conclusion that we came to is that a lot of these studies, and most of the studies that we looked at, kind of was part of research studies and small pilot studies. So often when services are integrated, it's also delivered at a higher quality. So for the purposes of the study, etc., for example, more advanced testing is available, etc., and that kind of leads to these higher costs. But similarly, we also saw instances of decreases in costs, which also are not necessarily directly related to integration. So, for example, where in a study, the cost of drugs decreased between the two time periods, and this is purely because of a regimen change, which is not, you know, affected by integration, for example. Then one of our main takeaways really is that the impact on costs at an above facility or broader health system level really is still very clear. So it's hard to kind of make these broad statements on you know, would integration or does integration lead to a more affordable health service in the long run? And this is also just a result of most documented examples of integration being as part of small kind of pilot projects, which haven't really been scaled up. And so aspects like, for example, whether information systems would need to be integrated, or financing systems, or, you know, what broader level of governance and accountability structures need to be created or boosted to actually facilitate this integration at that level, really isn't well studied or looked at. And then another significant gap that we identified is that we really don't, from the literature or from the deeper dive case studies that we conducted, understand what it actually costs to get the integration going. So what upfront investment costs are going to be incurred, despite, all the signals out there that likely there would be significant costs, especially around getting a health system ready to actually be able to absorb these services. Next slide, please. So very briefly then, just from our research, what have we learned around kind of the financing related sustainability challenges and opportunities for HIV PHC integration? So the first point I already touched on, and this is that even though a lot of the literature do show like that in general, integration is probably cost effective or cost saving at a unit cost level, it's not necessarily affordable for countries. And at the minimum, the real impact on government budgets aren't well understood. And this is really important when countries plan for integration, because we all understand the realities of primary healthcare and the significant constraints already faced. And then also when we think about financing specifically, a real challenge is addressing the current fragmentation in financing systems, and how do you actually merge off-budget funding with on-budget funding, etc. And how do you actually bring vertical funding into the horizontal or integrated system? And then key opportunities, one of the key findings that we did see from our case studies is that where integration, works well is where the health system can kind of respond and manage to kind of manage that additional burden that is on it when HIV services are added. So HIV PHC integration really is potentially a vehicle that could drive increased investment into health system strengthening. And I think what Lisa said around the UNAIDS roadmaps also speak to this. So like, how can we over the long run strengthen health systems to allow for more successful integration and for sustainability in the long run? And then one of the things that we've been thinking about as a team, and we've also been we're also supporting a couple of countries in the UNAIDS roadmap process, is what is the role of development partners as they transition, but also to perhaps play a role in this process in the meantime, in terms of key systems for strengthening for sustainable integration. Next slide, please. I won't go into too much detail, but this is one of the key outputs from the work that we have conducted, which is in the form of a small like a guidance document for countries that just looks at key considerations for country stakeholders planning for integration. And it really just defines a very simple and quite generic pathway to integration in terms of an 8-step process, where at each step, a number of key considerations are outlined, and a number of key questions are asked and posed to the user to try and make sure or to try and guide the integration planning process. And on this slide, I've just highlighted a few of the financing and funding related questions considered in this document, but we address the entire all the health system building blocks and kind of enabling factors in that document. I'll stop there and hand over back to you, Davina. Thanks.
Thank you, Elise. It was really helpful to get some of the highlights, takeaways, challenges, and opportunities from what we're seeing in the literature and practically across countries as we advance HIV and PHC integration, and especially for calling out some of those key considerations in your last slide that we should keep in mind as we move forward in this process. So thank you. And then now I'd like to turn over to our final speaker, George Ogola, who will be sharing out on how Kenya has been approaching UHC and PHC health reforms, integrating HIV into into primary and community health platforms. Mr. Agola is a health economist and health systems expert specializing in health financing and policy advocacy. And he currently serves as Path Kenya's Senior Technical Advisor for Partnerships, Advocacy, and System Strengthening. George, over to you.
Thank you very much, Davina, and good morning, good afternoon, good evening, everyone. I'm happy to present the case of Kenya, how the health reforms may result to proper funding and ensuring that HIV is integrated, more especially at the community level. Next slide. We take note that Kenya holds election every 5 years, and currently the Kenya Kwanza government under the bottom-up approach did secure parliamentary approval of key acts that are really making sure that resourcing health is really taken to the grassroots level. And therefore, it came up with the Primary Healthcare Act and the Digital Health Act, the Social Health Insurance Act, then the Facility Improvement Financing Act, which I'm going to speak to. And looking at all these acts, there is a overhaul of how the health financing is happening in Kenya. Next slide. With the shift, you realize that initially we could be focusing more on the curative aspect of health, and that is from the patient-doctor kind of perspective. But all these shifts have really moved us now from that curative only to a holistic approach to health, starting from the preventive all the way to palliative healthcare. And of course, trying to make sure that we digitize the systems and the medical records and even how we are managing the funds in a digital format, and that it brings a system that is really reducing the out-of-pocket expenditure. And this shift has led to the shift from the National Health Insurance Fund, which we used to have to call NHIF, to Social Health Authority. And so you realize that that particular shift has led to a number of things that are really both positive and negative as for now, because initially we had a narrow way of financing health systems where it could only apply for those who can afford to pay, as opposed to looking at or extending the services to the people who are needy, including the people who are disadvantaged. But then the shift to SHA is looking at how then do we bring in each and every person who is who needs the healthcare services without suffering a lot of financial constraints. And of course, we have a way in which we are now trying to exclude the fund, trying to ring fence the funds at the facility level to make sure that it is not diverted anywhere, but to serve at the facility for the most needy aspects of the healthcare service delivery. Next. We have our Kenyan Constitution 2010 that brought about devolution, and it ended up with 48 governments. That is the 47 county governments and one national government, which are independent and interdependent, and they depend on each other. But then you will find that each county has got the autonomy to do their budgeting and planning on their own. And there are functions that are devolved, health being one of the functions that are heavily devolved, where policy is left at the national level, but the planning and budgeting is devolved to the county level. Level 1 to 5 facilities are really the functions of the county government. And of course, that introduced a public finance management system where each county has got a county revenue fund. All the resources were being consolidated at that particular revenue fund is when they can be used to various departments. Next. We realize that this shift means a lot to the subnational level, And one of them being that, as I did mention, each county needs to do their prioritization for 5 good years to make sure that they include all their priorities in the county integrated development plans. And those priorities are the ones that on yearly basis are customized at the annual development plans. And those priorities are what are budgeted for using a program-based budget system, whereby the priorities of the county, especially the health department, are put in various programs and sub-programs. And that is where HIV interventions are also included as a sub-program of primary, that is the preventive and promotive healthcare services, and they are budgeted for there. However, we take note that funding for HIV interventions is still heavily donor funded, but then we are moving gradually to make sure that we are able to allocate more resources for those interventions. You realize that with the devolution, most counties are now allocating more than 20% of their resources to health department. But then we might see that as a huge percentage. But then if you'd go deeper into the analysis, you realize that the heavy part of that particular budget is heavily taken to the human resource, while it leaves a very lean budget that is for interventions. And most of, or some of the counties have taken another good practice to remove the human resource budget and take it to the public administration, so that the funds that remain are only those that are meant for operation and maintenance. And that you can now argue your case with the other departments, because you see, the other departments claim that, oh, we are giving you more budget. Why do you need more? But when you look at the human resource in health versus those other departments, health has more, and therefore it remains with less. And so those counties are allocating resources for HIV interventions, despite donors still taking the heavier part of it. And so we have got the FIF, that is the Facility Improvement Financing Act of 2023 that I did mention up there, which is required. It requires that the facilities retain 100% of the resources that they get from the raise from the facility. Some of the counties have adopted that and are using it the way it is. Some of the counties developed their FIF acts prior to this amended National Act, and therefore they were retaining 70%, while 30% is still taken to the centralized kind of account for administrative purposes, which is still now not a good practice, and therefore they are trying to align their acts with the National Act. The beauty of this particular act is that there is that financial autonomy where the facilities have got that autonomy to run their own affairs. And the shift from taking that money to the county revenue fund is that there is no likelihood of diverting those funds to other departments. A case in point, one of the counties allocated some resources for an intervention that is for blood services. Then 6 months later, those resources were diverted to land. The FIF Act does not promote that, because the facilities are going to be more accountable for the resources that they are retaining. And we have seen some of the facilities through the USAID Nuri Mtoto project that we implement in the western and Nyanza part of Kenya, where some facilities are now using the resources that they are retaining to procure very essential commodities and consumables that are aligned to HIV interventions. One of the facilities I know of just went to procure the test kits for a pregnancy. So any woman of reproductive age who steps into the facility, whether she came for whatever service, would be tested. If she is pregnant, is tested for HIV. If she's detected HIV positive, is now put on care, and that would prevent or eliminate mother-to-child transmission. So that's a good practice, that those resources that are retained at the facility help in procuring such kind of commodities to help in providing services. You'll see that with the funds that I did mention, Primary Healthcare Act of 2023, level 1 to level 3, and level 1, when I talk of it, is the community level. the shift from the NHIF now to SHA has enabled now the preventive aspect of care to be attended to and also be funded. So they are benefiting from the PHC fund, and that is currently capitated at 900 shillings per facility per year. So even the vulnerable households are now supported by the government to register for the social health insurance, and of course to use this at level 4 and level 5. That never used to be at NHIF, which only focused on the people who were working and who were in the formal sector. And from the provider perspective, it is indicated that HIV care is among the services that are declared free in the benefit package for the SHA. But then if you look at from the, the patient perspective, it is still not free because they incur some cost when they are going to get the drugs from the facilities. And so that may need to be considered. Next. And so what does integration mean? And of course, we realize that some of the facilities, or most of the facilities at the subnational level, initially there used to be integration in silos, where we would just say we want to integrate HIV with family planning interventions. We would integrate HIV with antenatal care services. But then this has been broadened, and we have now shifted from providing HIV from comprehensive care clinic, that is the CCCs, and going to ensure that services are provided at any service delivery point. And so there's also this bit of the combination prevention, and where we focused more on providing the PrEP, the post-exposure prophylaxis, the treatments, but then we are extending to some of the neglected behavioral and structural drivers, which include, but not limited to, things to do with family planning. How do we use family planning as a way of maybe preventing HIV/AIDS? And how is the gender-based violence really fueling HIV/AIDS, and how do we address such? That never used to be there. And also, we are realizing that facilities, to ensure that there's that integration and continuity of service delivery, we've shifted from just giving capacity to the donor-funded projects, that is the staff who are employed by the donor-funded projects, but now helping to support, give the capacity to the government staff, including the faith-based organizations, to ensure sustainability. In the event that the life of the project ends, the skills remain with the government officials. And of course, we've seen the government collaborating with the county, that's the national government collaborating with the county governments, and employed the promoters who are given stipend, and these people, their services extend to the community level. Preventive aspects extend to the household level, including the HIV prevention. Of course, we've seen that the HIV trainings, initially they never used to be integrated in the curriculum for the diploma and degree courses. These are currently being implemented so that the service providers start to know how to ensure that HIV care and treatment prevention is from the institution level. Next. So one last thing is that we have seen that, yes, there is the shift from the National Hospital or National Health Insurance Fund to the National Social Health Authority. But then the belief is that it should have been gradual because there are challenges that come with it, structural challenges, where, migrating people to the new model, sensitizing people to get to understand it, and making sure that systems are set to make sure that facilities are they are ready to get to, pull these resources from that particular pool. It should have been gradual, but then it's been, rolled out in, the whole country, but it's facing those challenges and denying people the services that they need at that initial stage of transition. And we're learning that lower level facilities, with the FIF Act coming, it might help the facilities, the lower level facilities, the level 2 and level 3, to have at least increased resources initially they were not supposed to provide services that are charged. They would not need to charge for services, but they would provide services and now forgo the user fee, but claim that from the national government. And they might not be raising enough to provide the services at a particular level. But with the shift to SHA, there are specific services that you cannot you cannot be given at level 3 moving forward or level 4 moving upward, but you will be referred downward. And we have seen a likelihood of losing even ANC mothers, for example, along the way, or expectant mothers along the way. Because of that particular downward referral. And of course, some counties have re-centralized revenue. As I did mention, 70% left to the facility and 30% or 100% to a pool or a central account, which is when it is now disbursed to the facilities, which still is beating the logic of making sure that we decentralize resources. Of course, we need to enhance accountability at all levels, because it's one thing to allocate resources. Counties might be allocating those resources, but then are those resources utilized? We realize the trend is that in Q1, Q2 of the financial year of the government, resources are not being disbursed as needed. They might be disbursed towards the end of the financial year, and that might mean resources might not be used as intended for the interventions they were intended to. Over to you, Davina.
Great, thank you, George, especially for that orientation on how Kenya is approaching their health reform process, how this is impacting integration and facilitating subnational management of health services, and most importantly, highlighting what these shifts really mean in terms of how people in Kenya are experiencing their healthcare services. And now we will have just a few minutes to take a couple of questions from our audience. So please feel free to add your questions in the chat. And I will hand over now to Dr. Linda Venotto, a Senior Program Director for Community and Primary Healthcare at R4D, who will take us through some questions and then wrap up. Over to you, Linda.
Thank you very much, Ina, and thank you to the three presenters. That was very insightful. A lot has been said and we have really learned a lot. I'd like to also appreciate those who have joined us. As Davina said, please put your questions in the comments if you have any. But let me start with you, Lisa, if you will. Yeah, thank you so much. That was a very important presentation that you gave us. We know that funders and donors have supported HIV work in countries and also globally, leading to all the successes that we have heard about in HIV. Remember the time it started and where we are now, and that has been great. But we know also that funding streams for healthcare have been siloed historically, due in part to several reasons, including the structural reasons, how donors structure their services, how they structure the funding that they give for health. And this somehow has led to verticalization as well as fragmentation of work in countries. So as we embark on this process to kind of address these challenges, are there strategies that you've observed that countries and funders can put together to minimize the siloed funding structures and facilitate integrating services at the country level?
Yes, of course. Thanks so much for the question, Dr. Vanotu, and I really appreciate the thinking there. It's this question of donor harmonization and alignment, really, to sort of hark back to the Paris Declaration's principles, is something that I think is critically important, particularly as we're looking forward to what the sustainability and of the future state of the HIV response might look like in particular. But I think it really extends much more broadly than that. So, as I think about opportunities that extend in some ways from the challenges that you've highlighted, I think a lot about really sort of the core principle of using and aligning to donors using and aligning to country priorities and existing country systems, and so an example of that could be something kind of in some ways as straightforward as as sort of working with and through a Health Development Partners technical working group that is stewarded by a Ministry of Health in a country, but offers a platform through which health development partners can have, regular exchanges about the thinking and the planning for how governments, would like to receive support from development partners, donors included. And those types of platforms, I think, have been successful in some cases in some countries, of allowing the conversation to happen, and sharing of information. As so many of the development partner organizations are really quite decentralized, USAID included, and others as well. And so, to the extent that those types of partner working groups offer an opportunity for country offices to exchange with partners, I think that there can be enhanced communication flow that's kind of afforded through such platforms. So I would say that might be one opportunity there. I think another is what Davina highlighted in the opening remarks about one health, one budget, one M&E framework. So to the extent that development partners can and are able to align behind the priorities of country health sector strategic plans, of national HIV strategic plans, now going forward within the case of HIV to the HIV sustainability roadmaps. These are documents that very clearly outline what countries are indicating are the priorities for their own health sectors. And then I think it really is, can behoove development partners to align behind those priorities and to set their, to the extent that's feasible, to set their development and funding trajectories in alignment with those plans and priorities accordingly. And then I think, perhaps more at the sort of granular level, there's opportunities for, co-planning, if you will, across development partners. And so I'm thinking, for example, about when a partner like a multilateral development bank, a regional development bank is developing a new loan program with a country and setting out what geographies it would address within a country. A partner like USAID can come in and work in a complementary manner, even targeting the same outcomes, objectives, outputs, but in different geographies, right? So that can help to really ensure that there's complementary efforts across development partners, not duplication, but to the extent that those planning cycles can align, then that can be another opportunity. Hope that helps.
Sure.
Thanks.
Sure. Planning cycles must align. Thank you so much. I'll move on now to Elise. Elise, from the literature review and the country case studies you conducted as part of this work, did you find any financing or funding mechanisms used by countries that intended to be conducive to integration of HIV services, and you would like to share with us?
Thanks, Lisa. Yeah, I mean, I think as much as this was one of our research questions that we wanted to try and address through the work we have done, because a lot of the documented examples really are focused on smaller scale pilots, we really did find very few examples of where financing has actually been integrated. And I think a lot of this is happening, but perhaps just not documented. And kind of the next phase of our work is trying to explore this more. But maybe just to say, I think it does tie in also with what Lisa has said, is to really work with countries and work with existing systems, and see how existing systems can work for integration, and rather than trying to kind of try new things. But where we did see an interesting example was in Zimbabwe, where VMMC was integrated into primary healthcare, or as part of a project as well, a smaller project. But there, the financing mechanism was also being piloted to be integrated into their existing results-based financing mechanism for maternal and childcare and other services. And that worked really well. And a part of the reason why it worked really well is that the donor worked with country to really capacitate them and to make sure that, local capacity was there when they then eventually left, because they did leave. The project came to an end and their support came to an end. And that worked really well because of that kind of collaboration during the, call it startup phase. And then also the fact that, you know, this RBF, results-based financing system, was already being implemented in the country for other services. So that's one example, but yeah, they are far and few in between, and we hope to discover them and also work with countries as they are exploring this. Thanks.
Thank you so much. And that is very good. Performance-based financing is key. Distinguished ladies and gentlemen, we have heard very insightful presentations. We have learned a lot of lessons. And I believe that there's a lot that as we go back to review them, we will take on board. But let me just end here by saying that USAID is placing itself quite appropriately to be able to respond to how countries should manage whatever support is coming to them. And I think one key thing is about the political commitment, which is important, that every country does that. Interestingly, we've also heard that integration means different things to different people. And it's not just about saving costs. So countries need to take this on board as they think through how they're going to integrate their services. And we have heard from Kenya how the devolution went on and what that has done. And here we can learn that innovations come about as people are given more and more autonomy. And so as we think about demystifying HIV funding as we go forward, integrating it into the existing PHC system, we need to be mindful of the fact that we have to align to the country's priorities and systems. And integration should also be gradual. I believe that I should go with documentation of the lessons learned, the challenges, what works, what doesn't work, and continue the global discussion as to how we can share experiences from different countries in terms of what is working, what is not working, and how funders can also come together to support countries as they move forward. We want to thank you all so much for your time, and to the presenters, we thank you for your time and the excellent presentations that you have given us. Thank you. Davina.